Hello, everyone, and thank you for joining us today for an in-depth discussion on the treatment of feline infection peritonitis, legally accessing and using antivirals. My name is Dr. Ian Sandler, and I am the chair of the National Issues Committee of the Canadian Veterinary Medical Association. Before I introduce our speakers, I would like to thank the CVMA for supporting this important webinar. If you have any questions, please use the chat section so our speakers can have an opportunity to respond. Please remember just to mute your speakers, as we have a lot of people joining us today, which is great. This webinar will also be available on the CVMA YouTube channel to view at a later date. Many of you know today's panel very well. Dr. Shauna Blois is an assistant professor and section head in the small animal internal medicine service at the Ontario Veterinary College. After completing her residency at the OVC, Shauna became board certified by the American College of Veterinary Internal Medicine in 2008. She is an active participant for the ACVIM, serving as small animal internal medicine representative on the Advanced Continuing Education Committee, as well as a member of the nominating committee. Dr. Margie Scherk is a graduate of the Ontario Veterinary College. She opened her cats-only veterinary hospital in Vancouver in 1998 and practiced there until 2008, publishing several clinical trials during that time. Dr. Scherk has served on several committees, including the American Association of Feline Practitioners, as well as many other organizations. Dr. Kelly St-Denis, or St-Denis, should I say, excuse me, is practicing feline medicine, and she is board certified by the American Board of Veterinary Practitioners since 2013. She's a medical co-editor of the American Association of Feline Practitioners and co-edits the magazine, as well as the Feline Journal of Medicine and Surgery. She is a consultant for VIN and several other publications. And finally, Dr. Scott Weese is a veterinary internal medicine specialist and the chief of infection control at the University of Guelph's Ontario Veterinary College. He is an expert in infectious and parasitic animal diseases, including rabies, tick-borne diseases, antimicrobial resistance, and emergent diseases. He is the former Canada Research Chair in Zoonotic Diseases, and he also writes and speaks extensively about infectious and zoonotic diseases, particularly on the Worms and Germs blog. And with that, I will pass it on to Scott.
Great, thanks a lot, Ian. Thanks for joining in, everyone. So plan for today is to give you an update on what we've got going here with FIP antivirals and then open up for discussion. So we've got a good group of panelists here to talk about how we use these drugs. So I'll try to be fairly brief in the intro, but we don't get many things that are really game changers. And this is one, antivirals for FIP, now that we've got access to drugs that can have a really high cure rate for an almost invariably fatal disease. So as you may have heard, the reason we're here is just within the last 2 weeks, we've gotten permission to import drugs. So we've got a legal access to these drugs that have been obtained typically through the black market and through dodgy channels in the past. So just really quickly why we're here and what our options are. So we've got really kind of 4 or 5 main options we talk about of potential antivirals for the treatment of FIP, and we need to understand their licensing aspects when we think about how we can access them. So if we look at licensed human products in Canada, because licensed human products, we can obviously use extra label in animals. We have remdesivir, Gilead's Veklury product, and then there's Paxlovid. Now, Paxlovid in brackets, because for me, that was kind of plan D if everything else failed, because we have no pharmacokinetic or safety data in cats. And what we little bit we know from dogs is dogs are different than people, so cats are probably way different. So it's not a desirable option. Remdesivir, we could legally use it if we can get access to it. The problem is the drug that's in the country is in specialized pharmacies and on government procurement, and they can't sell it to us. So it's inaccessible. So for that, and we look at beyond what's available for humans or animals in other countries that we can bring in through an emergency drug release or an EDR. So remdesivir, we can obviously potentially get because it's available in various countries, and molnupiravir, a useful but not as effective drug for FIP. The advantage of it being oral. Now, these are available for humans in a few countries, but for an EDR, a really key point is you have to get them directly from the manufacturer. You can't get them from an intermediary. So we couldn't contact a pharmacy in Australia, for example, and get them to send us oral molnupiravir. It has to come from the manufacturer. And for both of these, the manufacturers have said they aren't interested. Doesn't mean they oppose use of the drug, they're just not interested in getting involved. So they're not going to directly sell it to us. And that's why we've been at dead ends, and that's why people have been importing black market drug. Now, there are products available through legal channels. The challenge has been they're compounded. So a company in the UK, Australia, Abova, and I'll give more information on them later. They have legal compounded products. So remdesivir, GS441524, and I'll explain these in a bit. Molnupiravir, and then a molnupiravir relative, EIDD 1931. So these are legally readily available in those countries. The challenge for us in the past is the EDR process wasn't really set up for compounded drugs. It was set up for licensed human and animal products. And that's why we had time to get this established. But now that we've got approval, we have access to remdesivir and GS. So these are the two drugs that we're focusing on. Remdesivir is the human drug for COVID, as you know. GS is a related drug. Essentially, remdesivir gets converted to GS 441524 in the body. So it's the GS that has the activity. So there are parenteral forms of remdesivir available, and there are oral forms of GS. And the oral form being obviously nice because it's easier to give. There's less morbidity associated with the infections. And the good thing about cats is it's really readily orally bioavailable. It's not actually that bioavailable in people, but cats have a better absorption, better transport of it. And what we know is these drugs work, whether you're using them alone or in combination or serial, starting with one, moving to the other. And the standard reports are kind of 80+% resolution, clinical resolution. And one of the take homes is if they survive the first few days of treatment, the prognosis is actually very good. Most of the deaths that occur early in the treatment process because these cats are really sick. By the time they get started, it's maybe futile. So this is why I mentioned the game changer aspect. As you probably know, these cats can be really sick and get long-term recovery. We don't have multi-year follow-up on many, but when these have been followed up for months, still maintaining clinical cure. So these are, as I said, game changers. Now, so how do we access? I'll really briefly go through the EDR process. I won't go too much into it, but many of you probably haven't done that before. So again, it's a process we use to bring in drugs that are available in other areas. We have to justify why we need them and how we use them. And that's really important for it because the veterinary drug directorate has to know that we're using them appropriately, using them safely, and using them with a reasonable expectation of efficacy. Let's skip over that. So one thing, I can try to put this in the chat right now. So we have a Dropbox that we've set up that has the documents I'm going to mention here. And I'll see if I can copy it. Otherwise, I'll do it after we do the slides. It'll be easier then. So in that Dropbox, we have sample EDR forms that you can see how it's filled out. We have.
I'll throw it in for you, Scott. Sorry.
Oh, that'd be great. Yeah.
I'll throw it in for you, Scott.
That's great. Thanks a lot. So we have guidance documents. One of those you can attach to the EDR request that explains why we need the drug and why we've chosen what we do. There's information on Bova, the company that sells this drug, an account form and order forms. And just to be clear, there's no conflict of interest here. None of us are supported by Bova or anything. We've just been working with them to get access to the drug. So there's no kickback or anything. We just want to see cats treated. So those are in the Dropbox. We haven't put that available online because we want to keep it restricted to vets. So if you link it here, if you miss the link or you forget about it and want to get it later, you can email me or get me through Twitter. That's how we're getting the information out. We just don't want it in clients' hands so they don't come into clinic saying, here, fill this out or sign this. One thing I would say is the guidance can change, and we updated these last week based on some new treatment guidance. So if you're using the Dropbox or using the forums, I'd recommend you check back periodically. I'll try to date any updates so you know where we are, just because we do have a fairly fluid environment. So really quickly on the process, it's a very straightforward process. The paperwork is pretty minimal. It's pretty quick to do, especially when you've done it once, and especially if you've got the documents we have put together to guide you through. You don't have to use what we've put together by any means. It's just they've been successful. So obviously, first step is make sure clients are aware, and that's part of the EDR process is informing the clients about possible benefits, possible risks, and the fact that it's not approved for sale in Canada. Do the EDR paperwork, you send that to the Vet Drug Directorate. So the application form, we have that supporting file that explains why we're doing these things, and a fee form. I'll get to those in a little bit. Set up an account with Bova. I would recommend doing that at the same time. There's no use waiting for the to approve the EDR and then setting up the account, you might as well get that rolling. Once the EDR is approved, and that's usually a day or two, it's a pretty quick process as long as everything's right. Then the Vet Drug Directorate sends a copy to you, and we'll send a copy to BOVA, and that tells them they have permission to sell you the drug. And then you make your order. At the end of it, there's a follow-up form you have to do, and I'll show that at the end. You just have to make sure that we're explaining how we use the drug and what happens. So I'm not going to go through the forms in detail. They're in the Dropbox. They're completed as an example. You can change things, obviously, in terms of treatment regimens. We do have some changes since I put those forms up. You just have to put it in the drug that you want, the format, number of tablets, number of packages you want to get. The contact information for the company is already in there, so you can use that as the base. And then you need to explain why you're getting as much as you got. So here's the dose, here's the duration, here's why we want that much. So it's all pretty straightforward. One thing I really want to highlight is, and this is a really key thing and really, really important for us, you can order drug on spec. So you don't have to wait until you have that FIP CAT in front of you to order the drug, because we'd rather be able to treat these drugs immediately. So you can request a treatment course. You can't request bulk volumes to be dispensing it, but you can request a treatment course for a future patient on the assumption you're going to see one. So you're basically filling out this form saying, I don't know who this is for, but I'm guessing their age, I'm guessing their weight, and I'm guessing this is what we're going to do. And then at the end of the process, you'll fill in the details when you report that back to the Vet Drug Directorate. So if you have a reasonable expectation of seeing FIP cases, I would do this. It's going to speed up the treatment. And you can do this two ways. You can ask for the full treatment course, the full 84 days, or you could get 2 or 3 weeks. The advantage of getting 2 or 3 weeks is you have less money outlay, less drugs sitting there. The disadvantage is you have to do another EDR. So there's more paperwork, and there's the cost again, because it's new EDR, so you have to do a new fee, which is $57. So it's not a deal breaker, but whatever works best for you. But if you're seeing cats regularly, I would recommend having some available. The fee, like I said, $57. If you're doing 2, so there are different ways we could treat this, and I'll come to that in a minute. We're really moving towards going right to oral GS. Unless the cat can't tolerate an oral bed because it's really, really sick, we can go right to oral GS. If you're using injectable remdesivir to start, then we need 2 different EDRs. You have to have one for remdesivir and one for GS. You can't combine them on the same one. So if you're doing that, you have 2 EDRs, you have 2 fees, but $57 is pretty cheap. And then there's the follow-up form you have to do at the end. And the key here is just make sure that we're doing all the paperwork right, because we don't want to lose access to these drugs. And it's a pretty simple form. It's just explaining around, it's rounding things out. Here's how I used it. Were there any adverse effects? What was the outcome? It's just a follow-up on that. So I mentioned we've got these 2 drugs. We have injectable remdesivir. It can be given IV or sub-Q, and we have oral GS. Oral GS is what we're really trying to move towards because of a few things. The big one is adverse events. So with the injectable remdesivir, the pH is about 1.5. And if you've seen these cats treated, they can have really nasty injection site problems. And if you're injecting them every day for 84 days, there's a lot of pain, there's a lot of complication potential there. Oral, we don't have to worry about that. The oral product is about 1/6 the cost of injectable remdesivir. Easier to administer than in your cat, obviously, and it's at least as effective. And there's some thought that oral GS may be even more effective than remdesivir because it is so bioavailable, and it's easier on the cat. There may be some efficacy advantage. So in terms of cost, because that's the first thing everyone asks, here are the prices. I didn't put in the Canadian conversions here. So a couple of things I want to highlight here. We've got different bottles, sizes, whatever, different costs. If you say a 4-kilogram cat, which is erring on the side of a big cat for FIP, and we say the 84-day treatment course, you're looking at about 2,500 Canadian, 2,600 Canadian for a once-a-day treatment course. That's excluding the EDR fee, that's excluding shipping, your time, your markup, and everything. But the key point is it's not more expensive than the black market drugs typically. And some of these black market drugs are quite a bit more. The other thing I want to highlight here is there is an oral suspension that's available. So there would be an ease of administration aspect, slightly different cost. Big thing to note is the shelf life is only 4 months. And they've increased that. But this isn't something you're probably going to want to be buying in on spec. Something that you might want to bring in as needed. So if you start a cat on oral tablets, those aren't going well. You think you need to transfer the oral suspension, then you would do a new EDR asking for the oral suspension, explaining why. We just need to use a suspension on this cat because administration is a problem. And then you can get that in. And we just, so in the Dropbox, we have some treatment guidance. I updated this last week because there's some new guidance coming out of the UK. And this is from the FIP advice group in the UK who have ample experience treating cats and are doing research on it. The file that this is from is in the Dropbox. I think it's in the supporting documents file. It's in there somewhere. This isn't available online, I don't think yet, since it's just been released. It will be available online. I just don't think it is at the moment. So you can find it through the Dropbox. And it's a really good overview of treatment regimens, monitoring adverse effects, and a whole range of things. But I'm going to point out a couple of the key components here. So when we look at treatment regimens, we've got 3 different things we can consider. So we've got IV or sub-Q remdesivir, which we really don't want to use. Unless you had to, you could not treat the cat orally. It's just a hard treatment and it's more expensive. Where remdesivir has its main role would be in a really sick cat where you're concerned that oral bioavailability will be poor. If they're so sick that they can't absorb an oral drug, to start them on remdesivir, and really we're thinking 4 days because they tend to respond very well and transition them to oral GS. Most of the time, we can probably go right to oral GS. Originally, the focus was once daily dosing with higher doses for dry FIP than wet FIP and higher doses for ocular and in particular neurologic FIP. In the latest guidance that's come out of the UK is they've introduced twice daily dosing. And once a day works really well. You see those studies of 80+% cure rate. The thought is that some of these treatment failures may be associated with cats that are poorly absorbing the drug. So they're looking at drug levels and finding some have lower drug levels than expected, and twice a day dosing may counteract that. Twice a day dosing is twice the hassle, obviously. It brings up the cost a bit because if you say for dry FIP, we're looking at 6 to 7.5 twice a day. So 12 to 15 milligrams per day versus 10 milligrams if we use our standard once a day dosing. So there's an increased cost component. It's not horrendous. There's an increased hassle component. Most cats will respond to once a day treatment. It's kind of a pick which is best for the client in terms of finances, administration, potentially how sick the cat is. One thing to think about with twice daily dosing, though, is if they're not responding very well, or you've had a relapse, then we probably really want to get to twice a day dosing because maybe this cat is one that's not absorbing it very well. So I think in the perfect world, we would go twice a day all the time. We have a little more confidence in that. Once a day still is highly effective. And we go for an 84-day total treatment course. Can we go shorter? Probably. There is some work being done looking at shorter durations, and I assume that over the next few years, that 84 days will drop down. But at this point, that's where our data are. So the default for me is 84 days. You have a situation where money runs out, the cat becomes horrendous to pill, shelters might be an issue, rescues might be an issue. We get into if they've been responding really well, they've been clinically and biochemically normal for a couple of weeks, we can maybe push it and go shorter, but I would go in aiming for an 84-day treatment course. Adverse effects, I mentioned that for remdesivir, injection site issues are the big problem. You can see some increases in ALT, maybe ALP, maybe creatinine, eosinophilia, pruritus. None of these are really major issues. The injection sites are the problem. For both GS and remdesivir, GS-associated uroliths have been identified. These are quite rare too. It's just something to note. With oral GS, it seems to be a remarkably safe drug. Very few adverse effects. You can have vomiting and diarrhea with anything, right? But that seems to be relatively uncommon, especially compared to antibiotics. Pruritus gets reported. That tends to be responsive to supportive care, antihistamines, and maybe it's more common with the black market drugs. I see it mentioned more in people that are buying in black market drugs than things from the compounded product. So just something to note. Monitoring really depends on the amount of money that can be put into it, how sick the animal was to start, how close they are to you. Typically, we expect to see good clinical response within a day or two. And if they don't, then I think you want to back up and rethink the diagnosis. And if you're going once a day, you'd probably want to transition to twice a day. Monitoring body weight is really important because we're looking at a prolonged treatment course in cats that are pretty sick. They should put on weight. They might put on a lot of weight, so we need to make sure we're keeping up with their dosing. Hematological rechecks really depends on how sick they were, how abnormal they were. Ideally, we're getting baseline in at least 2 weeks and 6 weeks, and ideally a couple of weeks before the end of the treatment course. So around 2 weeks or a month before the end, it'd be nice to see that they're clinically normal and hematologically normal prior to stopping treatment. This is an area we're still trying to work out a lot more about what predicts relapse. But at this point, we want to see them stable clinically and ideally have resolution of hematologic abnormalities before we stop. For relapses or poor response, obviously check the dose, check compliance, make sure it's being administered properly. If there's a problem with pilling, then maybe move to an oral suspension. Consider a dose increase because maybe they're a poor absorber, or more likely go to twice a day dosing if once a day was started. Therapeutic drug level monitoring is something that we definitely have some interest in. I'm working on to see if we can get some of this set up at a research basis to start. Ideally, in the long term, we would do therapeutic drug level monitoring maybe once or twice as treatment starts to make sure they're in a level. It's not there yet, but I think this is something that we might be able to get done down the road. If you're really getting poor response, rethink the diagnosis because they tend to respond really well. A couple of quick things to end off, and then we'll move to our Q&A and our panel. Other options, so interferon, omega, polyprenol immunostimulant, mefloquine, they've all been mentioned. They really aren't recommended by the UK group as a treatment. Mefloquine mainly has been positioned for situations where people can't afford to use a high dose of GS, or they can't afford to use a proper course. It does have some antiviral properties. We don't really know efficacy on it, and it's just adding in a drug that's probably not necessary considering how good GS is. And then steroids. The general line on steroids is if you have to use them, but only use them if you have to. Right? If there's a clinical need based on uveitis, it's a neurologic disease that might be necessary for a short course. IMHA, might need to manage that, but we're not going to use steroids as a routine tool. Again, they respond really well and really quickly to GS typically. So steroids are going to be reserved for the population that really needs that initial anti-inflammatory blast. And then care during treatment. Let's talk about not wanting to stress these cats out, which makes a lot of sense. But we have to be somewhat balanced on that. So I rarely pass up a chance to vaccinate. So vaccinate. Once they're clinically stable, which is usually fairly quickly in the treatment course, if they're due for a vaccine, vaccinate them. If it's a young cat and it's not adequately vaccinated, the risk from the disease greatly outweighs the risk from vaccination. Ideally, they don't get spayed or neutered during treatment, but if they have to, go ahead. If it's a rescue shelter situation where it has to get done, if there are behavioral issues or medical issues where it has to get done, it's considered okay to do it. But in general, we would try to avoid a stressor during the treatment course. So with that, I think we're just going to open it up to questions in the panel. Looks like the chat's been busy, so I don't know if anyone in the panel wants to jump in to clarify or add on things. Otherwise, we'll just start picking up questions and go from there.
I can pick up on a couple of the questions. Yeah. Certainly it sounds like there's some personal experience with FIP, and my heart goes out to anyone who's had a cat with FIP. I haven't had that, but certainly I've seen our patients go through that, and it's absolutely heartbreaking. And so I do want to acknowledge that, yeah, there's a lot of great data out there that has been crowdsourced through FIP Warriors, and by no means do we want to dismiss the data that's been generated by those sources. I think that some of the questions were around the costing of the FIP Warriors or the other sourced GS and what we're expecting to have the cost of this product. In Southern Ontario, based on our experience here, the cost is probably going to be equivalent or a little bit less when we're using Bova, at least here in Guelph. But I think that that's going to vary depending on your source. I think as well, there was a question about the oral versus injectable. It's not a perfect study, but there are 1 or 2 studies looking, and again, they're not huge studies, but there are 1 or 2 studies looking at both, cats that have been treated just injectable versus oral comparison study, and those seem to be equivalent outcomes. And then there was also a study out of Australia. It's a larger study, I think 300 or 400 cats that went for injectable remdesivir and then transitioned over to oral GS. And those cats versus staying on injectable were pretty similar. I think our experience here, it's been a lot of the owners will start with injectable because that's what we had at the initial onset of our access. And we were a bit suspect too of switching over to oral based on some of the crowdsourced data data. I had so many owners, I think, go through the injections and the pain at injection site that as soon as the first glimmer of evidence of oral bio, or at least clinical equivalency came out, we started switching over to oral just for feasibility. Very anecdotal, but it seems like the outcomes were on par with what we were doing when we were really struggling through those 84 days of injections. I don't know if that helped any of the questions that were coming out, but and by no means am I a FIP expert. We've been seeing a lot of these cats, and so it's just the experience that our clinicians here are accumulating. But if there's any questions about that, or if I haven't addressed something properly that came up in the chat, please let me know.
And maybe I'll jump with a couple in the chat, and then if others wanted to come in. So there's a comment there about from Joseph about 2 products have been specifically approved: the injectable remdesivir and the 50 milligram tablets. We didn't ask about the oral suspension, so I would not say that the oral suspension is not included in that. Just in the EDR we put in as our test case, and we were working through with the BDD. We didn't ask for the suspension, so I can't see any reason why the suspension wouldn't be part of that. Yeah, and I think you can get other drugs through BOVA, but those aren't things we're recommending. We're focusing on the 2 drugs that we have the most efficacy data for and the safety data for. And then maybe just one more thing. There's a comment there about the black market FIP warriors thinking oral is not as well absorbed. This really has evolved over time, and part of this is product quality, I think, and part of this is understanding what's going on and who's being treated. FIP Warriors Canada, one person I talked to there, they're quite enthusiastic about moving to the legal product, which has been really good. So I think we're going to see fewer people asking about the black market stuff. One of the issues with the black market drugs, and I put something on Worms and Germs blog about a week or so ago, that is that the product quality is really variable. We look at a licensed product, they're supposed to have between 95 and 105% of the label claim in that tablet. The stuff you buy black market's all over the board. Some are really, really high, some are low. The initial thoughts about oral GS bioavailability were that it might be poor, and that probably related to the quality of the product that was being brought in at the time. And I think we look over the course of time, it gets better. And there's a study that they looked at sub-Q versus oral GS in cats, and they found out the pharmacokinetics were basically exactly the same. So the absorption of the oral product is very good. And I guess from clinical use, with the UK driving towards almost exclusively oral GS now, they're quite confident in that. So there can be some cats that won't absorb as well, and that's why that twice-a-day dosing is going to be up there.
Claire's asked, what's the shelf life? And you'd said, well, it's 4 months. Rebecca, you have a question?
Yeah, 4 months for the suspension. The tablets, I think, were 18 months. It's in the, if you look in the Dropbox, there's the BOVA order form or count form. If you scroll down, you'll see the drugs, and that has the cost and the shelf life in it. And I'm pretty sure it's 18 months for the tablets.
Yeah, and I had created in the form too a conversion, with currency conversion sort of thing for Canadian dollar prices for it. But Rebecca Jackson has her hand up.
Yes, so I'm a student with Rebecca. I just have a question. How long does it take to get the legal drug in with the emergency drug release?
Scott, you'd already answered that, but Shauna,
about a week. Yeah,
Scott,
a week.
Around a week. It depends on. So the EDR should take a day or two. They're pretty quick with that. If you have an account set up with BOVA, that's going to speed things up. You're really at the mercies, and I think BOVA moves product pretty quickly because they know they need to get this out pretty quickly. You're really at the mercy of customs and the courier. So it depends where you are. I would plan on. This is why I think that if you see a lot of cats, have some drug in clinic, have a treatment course in clinic, because I think it's going to be at least a week. Maybe you get lucky and it's 6 days, depending on what day it gets ordered. It might be up to 2 weeks if you get delays at the border or in shipping. So if that's all you've got, or if you've got a cat that's on black market drug right now and you want to transition it, then the time's not as important. But I would plan on that week to 10. I think we were, Allison, was it 9 days for the first one we ordered, but there was a delay at customs and a delay with the courier too. So that was a little bit on the slow side.
Well, and weekends don't help.
Yeah. And the question about the Dropbox, I'll put the Dropbox back in there in case someone joined in after it had been put in.
Yes, when I was researching, it said the median survival time was 5 days. So if we don't get that drug in time and we don't have it in clinic, could owners potentially use the black market drug? Because I believe it takes like 24 hours to get that in.
Yeah, you can meet someone in a parking lot and get it same day, depending where you are. This is just, we have to walk that line. Like if they come in, like if you don't have the drug in the clinic and they want to source it and start treating, but transition to you, then I think that's, you know, it's not unreasonable. You know, we're not going to recommend that as the approach. We have to keep a distance from it, but from a practical standpoint, that's what's going to happen. But I think we really want to get them transition to the oral drug, the legal drugs as quick as we can. A, because they're legal, we've got safety, better confidence of safety, and we know the product is going to have what it is. But that's not unreasonable. They come in and say, I've got this stuff, I'm going to start treating it. Can we switch over to the good stuff, the legal stuff, when you get it? Absolutely. There shouldn't be anything, and this has been a very common question I've had, is that shouldn't preclude you getting an EDR. I think you just say that you're treating this cat, and I mean, sure, whether you say they're using a black market drug, but you need to have access to treat this cat with FIP, and I think that should be fine. I think they understand that we're doing this to get animals on legal treatment. And sorry, others jump into it in case it's talking too much.
I think a number of people are commenting that they don't find, they don't see many cats with FIP, and therefore they don't think they, should have it on hand, and especially with the cost and with the short health or with the shelf life. And again, I just want to reiterate, I think that, a single cat, saving a single cat is really worth having it. It's going to last long enough. You've got if you've got at least 18 months on the tabs. And there's no reason, there's no reason to have, you don't have to start them on the injectable. You could start them on the tablets, and therefore, if they're going to last 18 months, I think it's pretty likely you're going to see a cat with FIP within 18 months.
Yeah, and if you order 2 or 3 weeks of drug, that's actually fairly cheap. So you have that in stock, and then when they come in, it just means you have to do the other EDR and the other $57, but that drops your outlay a lot. And if you got 18 months, you're probably going to see that. One other question I was going to jump in on, and then before I get back to you guys, is a question about insurance companies. So I've talked to one company. I think odds are good they will cover it since it's a legal approach. I haven't got an official, I'm not going to say that for sure. Every company needs to be somewhat different, but this should be, it's a legal drug. It's just like treating a leishmania with meglumine that we bring in. My suspicion is if it's all done in legal processes, it'll be covered, but that's still a pretty fluid area since I think they're just adapting to seeing what we're doing. But for insurance companies, it should be a big selling point, right? If they'll cover FIP, that would be a great way to get people to use insurance more on their, new stray kittens.
Yeah, and Trisha's just commented that one of her RVTs had Trupanion cover the black market drug.
Yeah.
Wow.
At the start they did, then they stopped. They were doing that for a while.
Yeah. I would hope not. Sophie Chabonneau has her hand up.
Yes. So I was wondering about the urinary stones. What about the management of these? Because I think it's a new type of stone. We don't know, right?
It's made of GS. Yeah. It's like you can see, because you can see ciprofloxacin stones when you use enrofloxacin, because you get kind of concretions of the molecule that's there. I think for management, it's going to be removed. I don't know, Shauna or Kelly.
Yeah. It's interesting. Our residents chose that article for Journal Club on Friday, so they got me all up to date on these. But the 2 cases that were reported in that case series were on the higher doses. I think they were both like one of them at least was a neuro-FIP cat. Oh gosh, they're probably listening and seeing my poor recollection of their Journal Club presentation a few days ago. But these are, at least the cats that are reported, seem to be on the higher doses. It's going to be, for us to know long-term, like how common is this? And, maybe something that we can study over time too, to see even are there crystals in the urine now that we are getting together and hopefully getting more information and working together on these questions clinically. But I think removal, it doesn't seem like this is something that we know enough about to try to dissolve or whatnot. Yeah.
Although, making sure they're well hydrated and are on through canned food and fluids is probably not unreasonable, at least until we see, and that goes for everybody. But I think to not put somebody on it because of the very small, what appears to be a very small risk of these stones would be potential.
Massive number of cats have been treated, right? It does seem really rare for the massive number of cats.
Yeah. Oh, so it's been rare, very rare.
There are 2
so far, but I think as we see more and more cats treated with legal drug, we might get more information, and whether it's just remdesivir or the oral, probably both. And timing, is it months, years? So I think it just should be on people's radar, and it's a fair trade-off for life. So, and yeah, from my knowledge, they need to be surgically removed.
And there's another,
sorry,
and maybe another thing that's, sorry, go ahead if you had something.
No, I'm just reading questions here.
Okay. One thing, I'm not sure I saw it in the questions, but one thing that's good to note is if you order in a treatment course and you don't use it for that patient, you can use the drug. So you order in 84 days, you start the cat on it, and the cat dies after a week. That's something the BDD has said we can still use. So you would just report that. So you're finishing up your EDR follow-up for the first case, we use 7 days and cat died. This is what it was. And then you could use the next patient. And then when you order more for that patient, you would just indicate that you're ordering to complete a course for what was, started with what was already available. So you don't have to throw the drug out. As long as the drug's in our control, right? You can't send it home, get the drug back and redispense it, because once the drugs come out of our control, we can't resell it, right? So that speaks to, especially in the really sick cats, maybe only dispensing a short course. So have the rest in the clinic and then dispense it as needed, maybe longer durations as you get more confident, just so you can use that again.
Well, and then back to what you said before too, you can get in just, sort of order in 2 weeks worth, see how they do, or get them going on it, so that you have 2 weeks worth in the clinic, and then when you get your patient or your patient's responding, you can then order more, and it's just the extra cost of the EDR, but that should not be where we're nickel and diming. Yeah. There was a question here is, would clinics sharing the drug be legal? Like if we got together and one of us got it for future use, could a neighbor clinic use it instead? We're not supposed to be, at least in British Columbia, we're not supposed to be pharmacies for each other.
Yeah, that's it. Like the EDR is for you and a specific patient or a patient to be named in the future. We can't dispense it. So what you could do is if you had a clinic that had it, you would have to transfer the patient. They establish the relationship, they start treating. And then you could do the EDR saying, I've got a patient that's being treated elsewhere. I want to continue the treatment course. I'm pretty sure that would fly because that fits within all the rules and veterinary patient client relationship. But you can't sell it. Like at OBC, we have some, we can't dispense it. We would have to treat a patient here. And then if you wanted to transition, we'd have to sort that out. So it has to stay under your control for your patient. If there's anyone to the BDD on here, I'm not sure if there isn't, if they want to jump into, if any comments, if there's anything to clarify. I was going to follow up with them shortly to see as the process is going on, are there any things they're flagging as things we should be thinking about or improving or whatever, so we kind of keep them happy and keep the process equivalent.
Shauna, you just commented about the AG ratio not necessarily being as helpful. Well, certainly you have to make sure you have a low albumin, not just a high globulin, because high globulin is from anything. But you also commented on using PCR, and I'm just curious there, because what are you PCRing on? Because my understanding is using the real-time PCR on blood, you might as well do a whatever the effusion test is. I mean, it's
the Revolta. Yeah.
Revolta, that you really do need to have an effusion or a tissue.
Yeah, and recognizing that I'm in a different diagnostic situation often than a lot of our referral practices are, just because we're seeing sicker cats, and so sometimes the intensive nature of the diagnostics is a bit different here on the medicine service. Generally, an effusion I'll send out. Occasionally, we do have aspirates from like an unknown, what later we know is a granuloma in the cat as well, that we can always use for PCR testing. But I also made the comment that sometimes we get a negative PCR, and I understand as well, sometimes the PCR just financially is not going to be feasible for every client to do. We get a fair number of positives, but it is, sometimes we have a negative and we still think that just based on the rest of the clinical picture that it's FIP. So there are genetic mutations that will not be captured on the PCR that's currently available. And I think that it's one of those things where it's just one more piece of evidence to support your diagnosis if you get it. But if you have all the other clinical markers, the comment I made is, some of these cats, we make a presumptive diagnosis, even usually a PCR takes a few days for me to get back, at least a few days. So we're often starting treatment before that result comes back anyway. So if you have a really high clinical index of suspicion, like a lot of the diseases that we treat, we will treat. And usually these cats look like they're recovering within a few days. So we know we're on the right track, or maybe we've inadvertently treated something else, but generally the response to treatment will show us that we're on the right track. Or if they're not getting better, then we're raising suspicions of maybe something else, or really refractory FIP, which I haven't really had a lot of experience with.
So there's been a number of questions about diagnosis, and I just put a link into the chat box to the ABCD fact sheets, which are very helpful in clinical practice. So just look at the different types of FIP and your diagnostic suspicions. And then there's also a guidelines from the American Association of Feline Practitioners on diagnosis of FIP that's available at catvets.com. So if anyone's looking for those, they're easy to access and they're great things to have in your practice to help you work that way through that suspicion of FIP quickly.
And I think back to the response to treatment aspect, like Shauna is saying, like that's, it's very kind of clear. Like if they're really sick and they get better really quickly and you haven't done a lot of supportive care, that's pretty convincing as FIP. That's not something that's going to be a problem with the EDR process. Like there's not a requirement to have a PCR positive or whatever to import the drug. You need to think the cat is FIP. So if you have a strong clinical suspicion or an adequate clinical suspicion, that should be enough to get an EDR because we don't have a single highly sensitive, highly specific test. You know, we've got some good tests, but often we have these ones we're not really sure with the dry FIPs or the neuro FIPs. So don't be afraid to try the EDR or use something you brought in on spec in advance of a patient. If you think clinically there's enough justification to treat, that should be enough to get the EDR.
Two things, Rosalie, you've said I'm a bit confused. You're saying that we need to order it for a specific patient, but earlier you're suggesting we keep a few days worth of treatment for future patients. Yet you can have, have a couple of weeks worth. You can order 84 days worth, whatever. The vet drug directorate, whatever they're called, the VDD, is understanding that you can't. That you need to treat these guys right away. So you can have whatever amount you want on the shelf, and then when you do need to, when you order more for a particular patient, if you have like 2 weeks worth, also you have to follow up, and that's where you need the patient's name. Scott, you want to clarify on that?
Yeah, that's basically it. So you can order a single treatment course or part of a treatment course on spec. You just at the end have to say it. So it still has to be for a patient. So after you start treating the patient, you're done. You fill in that report form for that order that says, here's who we used it on, here's all the stuff that happens. So you can't order in a bottle, you say, or package of bottles where you start saying we're going to treat wherever. It still has to be on at the approach of being, this is for an individual patient. I just don't know I don't know the name right now to put in the EDR. And then when I know it, I'll fill up the follow-up report that will have all that information.
And that's why in the EDR that Scott's created, the generic EDR that's in the Dropbox, that is in the chat box, that is in everybody else's box, now talks about like it has approximately estimated 1 year of age. Estimated whatever, because but the very fact that we don't know who we're necessarily treating. Scott, there have been a couple of questions showing up about what about neuro, what about ophthalmic, and that's, I thought, was interesting coming in from the UK group, from the ISFM guidelines, and then that stuff's also in the Dropbox, that they're suggesting slightly different courses of treatment.
Yeah, so that's in the guidance we got there. So the doses are higher for ocular and neuro FIP, in particular for neuro FIP, just because their barriers is harder to drive the drug across. So you increase the dose to do that, or go twice a day. And we don't know for ocular neuro whether high dose once a day or twice a day is better. Probably twice a day, but it's hard to say. I think just we're going with a lot of the guidance out of the UK right now. A lot of work's being done trying to sort out some of these, and to sort of, there's a question about relapse rates tend to be fairly low overall. I think you see 10 to 15%, not uncommonly. We're trying to sort out whether there might be predictors for that, whether that's dose, whether they're sort of clinical things. Like you're going to see this field move a lot in the next year or two. Now that we have a legal drug, we can actually do real research on it and know what we're studying. So there'll be a lot of unknowns still right now.
So there's a question also about the that Shauna addressed about the Cyprus FIP, and I thought this was a perfect place to mention that we're going to have a presentation on that from Dr. Danielle Ganmour at the ISCADE, or International Society Companion Animal Infectious Disease meeting, October 13 to 16 in Vancouver. Please come. But it's not going to just be about that. There's going to be a whole bunch of stuff on FIP in the clinicians' day. So that's October 13 to 16th. Yes, I know it's right over Thanksgiving. Where better could you spend Thanksgiving, Scott, than in Vancouver?
Exactly.
Sorry, go ahead.
No, go ahead, Scott.
Just see a comment, do remdesivir and GS work in a similar fashion? Yeah, same drug. Remdesivir is converted to GS, and remdesivir's got a very short half-life in the body. GS sticks around for longer, so it's GS that's doing most, if not all, the activity. And if people are wondering about the Cyprus thing, I'm try to find a link here. So the Cyprus issue is an outbreak of FIP in Cyprus that may or may not really have been a big outbreak, but there's concern about the strains that were found that it might have been transmissible form of FIP, and we really don't know at this point. So
have a look at Worms and Germs blog, Scott's amazing blog that, you know, we get something every few days. That's always very concise, and Scott's written about the Cyprus outbreak, which may simply be there's a heck of a lot of cats in Cyprus, and therefore proportionately it's no different. It's just there's a heck of a lot of cats, and there's a heck of a lot of FIP, but the strains may be different.
Any other questions, anyone?
Yeah.
Anything else you want to jump in with, Kelly, Shauna?
I'm sure there are questions that I didn't get to in the chat. I was trying to keep up and also trying to pay attention in case Scott asked me a question.
Hey, Ian, did you see anything we were missing? We probably
I just sent you a couple of questions regarding the initial cost for EDR and also shipping and custom clearance, if there are any costs related with that, Scott.
Yeah, so the EDR is $57. Shipping, I'm not sure. I know Bova was working to bring the cost down. They were able to, for some reason, they had to send the drugs separately initially, but they said they've been able to combine them in the same package now to drop one shipping cost. I don't know how much that's going to be. It's not cheap, but in the grand scheme, it's not a big deal. But someone might have done this because, you know, we just kind of shows up as our approach here. It's the problem with a big place. We don't know where some of those costs go.
Avril, I don't know what the markup is here at OBC. It's variable depending on the drug. I haven't actually done the math, and yeah, I'm not sure numbers wise. But Scott, I think if we're saying like $2,500 per treatment course, so let's say even you double that. I don't know. That's like I'm not a business person. I'm in academia for that reason probably. So even if you double it, you know, we're looking at costs of, you know, I had like a year or two ago, I had clients reporting $6,000 for the treatment courses, and it's gone up from there. So at least that's the regional price. I'm sure that others will have different pricing based on where they are. Oral is going to be more expensive than injectable usually, but Scott, I think you had a quote from a little while ago, over $10,000 for a treatment course.
Yeah, if we look at even just with a Bova remdesivir, it's about 6 times more. So if we went 84 days of remdesivir from Bova, it'd be about 13,000 Canadian versus 2 something for a 4 kilogram cat, right? So it's on the high side. In terms of markup, I think most places mark up expensive stuff a lot less than, you know, the typical markup. And I'm not sure I could really say more than that because I've heard of marking up here, but I don't know if we're really allowed to talk about that. But I would say that most clinics, you have to kind of look at the scenario, I think. And a smaller markup and expensive drug still makes to make it worth your time. Something else I was going to say. Oh, for Bova in the Dropbox, there's the Bova order form and the Bova supply, whatever clinic account form. There's also on the EDR, there's contact for Bova, and there's the email there. Emma Jones is the main contact there. Her email address is on the EDR. So yeah, that would be, you fill out the account form, send that off. If you need to talk to Bova, there are 2 email addresses there. And again, to the process, what someone was asking is you submit the EDR request. When it gets approved, Bova gets a copy and you get a copy. So that gives Bova the permission to sell the drug to you, and it lets you know that you've got permission to go ahead and buy it. So once you get that approved, then it's just between you and Bova. You contact them, you make the order, and off you go until you have to fill in the paperwork at the end.
Yeah, the question about Gilead having a production firm or production unit in Edmonton, maybe they'll be more interested there, but Gilead in California is 100% not interested in the cat market. They want to make sure that that may be unfair. They want to make sure they have enough product for people.
And I really don't actually. I'd really want to stay away from it at this point. Like we were really looking at remdesivir, Becklary, the human product as our first thing. And now that we've got access to oral GS, like I don't want to go anywhere near the human product because A, it's going to be really expensive. We're back to that 13,000 plus, and we don't want to be injecting these cats for 84 days. We've got a functional useful oral option. So the last thing I want to have is restriction on access to the oral GS because there's injectable human product available. So I'm hoping it doesn't become an issue. But like you said, Gilead, they're not opposed to it being used in veterinary medicine. They just don't want to be involved in it in any way.
Any other questions for the panel?
I just wanted to mention, I know we were kind of questioning whether we should mention this or not, but I just because in case you come across, there's a little bit of muttering going on about treating cats, preemptively to get rid of, this is work that's come out of, well, it doesn't matter where it's come from, to get rid of coronavirus, to make cats coronavirus negative. And the big concerns there are, one, it's you can't make cats, I mean, if you eliminate it from them, they're going to become infected again. Two, and this is the huge one, I think, is the we really don't want to lose the efficacy of these drugs because this is a virus. These are viruses that mutate like crazy already. And so we don't want them mutating and becoming resistant to these drugs and taking us back to where we were 3 years ago and for the rest of time. And then finally, also, not every coronavirus positive cat mutates into FIP. So I don't think there's any reason whatsoever to, and the VDD would have a canary. They'd shut us down, I think, then. Anything else there, Scott?
No, I think you covered it. We don't have efficacy data. We don't have evidence of need. It's an endemic virus. We're not going to get rid of it. And BDD would almost certainly say no if you put it in to treat it that way. And if you try to use your FIP drugs for that, then that would be contrary to the BDD, and we don't want to screw it. And the big thing, this is a game changer, right? But I'm really loath to see us screw this up by using it indiscriminately. So if we have reasonable suspicion of FIP, absolutely use it. If you've got a cattery that's got a lot of feline coronavirus in it, we're not going to use this as prophylaxis. We can't eliminate an enteric virus that's endemic like this. So even though it gets reported, I would be really, really, really hesitant to go there.
Do we have any closing remarks from any of the panelists? Oh, I think
not a question,
has a question here.
But a comment, if I may. As somebody who, probably the only person participating today that remembers the great Jean Holsworth writing the first clinical description, good clinical description of what was to become FIP. I was a vet student then in 1963, so it's 60 years ago that Jean gave that description. And then through that golden age of feline virology, when we had panleukopenia virus identified and feline leukemia, and then FIP, and how wonderful it is now after all these years to see a successful treatment for this horrible disease. So congratulations to all those that have worked on identifying it, and to the panel today. It's been a very interesting discussion. Many questions, a lot of participation. It's all great. Thank you.
I just want to thank Dr. Povey. You were the first person, I believe, to create an FVRCP vaccine. So your role in feline vaccinology is huge. Thank you so very, very much.
Well, that's kind. Thanks, Maggie.
I think he saved a few dogs as well, Margie.
It's been great experience.
Thank you, Dr. Povey.
Thank you, Dr. Povey.
Yeah, absolutely.
Thank you, guys.
We've had a really good set of questions, and I know a lot of people will continue to have questions when they're presented with cases, not just for accessing the drug, but diagnosis. There's a lot of supports out there for you. I know that sometimes people will come on to the Feline Internal Medicine Board on VIN, but again, you want to probably interact with Canadians because they're just working through this process now in the US. So if we're talking about actually accessing the drug, but I have put a lot of links available for resources to look for diagnostics. And as Scott's put this Dropbox together, there's a lot of treatment information as well. So as much as we can help, we will try.
As well as those for clients too, from the ISFM client information on treatment.
Yeah.
And for updates, I'd say keep checking the Dropbox. Like I said, we'll update those. I tend to put any updates on Worms and Germs blog. And I'm Weese_Scott on Twitter, if you're looking at that. We're going to keep trying to make sure that we get everyone updated one way or the other of any changes. So now that we've got the twice a day thing that we knew was coming, that's probably the big change for now. But there will be some other changes as we learn more about, refining some of the dosing and drug monitoring. And there may be some requests from us to try to get some data too, because I think we really need to understand this disease more. So now that we've got legal access, we really need to figure out in Canada how we can start getting some real data to predict relapse and look at drug levels and things like that. So
yeah, and Liz Wilson said she's had over 20 cats who are out 3+ years and still going strong. So that's really useful. Liz is on Vancouver Island.
I just treated an 11-year-old cat the other day for hypertension, who was one of the first cats in our area like 5 years ago or whenever the black market drug became available to be treated for FIP. So he was an older presentation, but he successfully survived FIP and now he's hypertensive.
I'd rather be hypertensive than...
Yeah. Yes.
So Kelly, can you just drop because I know you have it on your, drop the Dropbox again link. Colleen has asked, where is the Dropbox?
Yeah, I did give it to her, but I'll put it there again.
Okay, great. Yeah, I have such a... Very cool. And again, come to Vancouver, October 13 to 16. She shamelessly promotes for the National Society of Companion Animal Infectious Diseases, where you won't just learn about FIP. There will be doggy stuff and other less interesting stuff as well. But yeah.
It's going to be great.
Well, we're just coming to the top of the hour. Again, I want to thank the CVMA for hosting this very important webinar today. It will be archived. It will be available on the CVMA YouTube channel. And again, to our 4 panelists, thank you for leading the way and presenting to us today. We really, really appreciate it. So again, thank you for everyone for attending.
And that's all Scott. It's all on.
Yeah.
Thank you, Scott.
Big kudos to Scott. Big kudos. Thank you, Scott.
Thanks, everyone. Have a good day.